Hello, everyone. I am so thrilled to be able to introduce Dr. Hilary Seligman to you all. I had the great pleasure of first meeting her maybe like 7 years ago or so as a collaborator with her on a study that was called Fresh Foods that was looking at ways to work at the food bank systems level to bring more fresh produce downstream to partner agency and other program sites. Dr. Seligman is well known for her work and research in food insecurity, diabetes, and other health outcomes. Her list of credentials is more than I can memorize, but she is just a wealth of information, and I'm hoping that she'll be able to inspire you on where your projects will really be able to go. She is core faculty for UCSF Center for Vulnerable Populations, and she's also the director of the CDC's Nutrition and Obesity Policy Research and Evaluation Network, also known as NOPRIN, which is on her slide. If you have never visited the NOPRIN website, I would encourage you to do so and consider joining one of their work groups. They have such great materials for the type of work that you all are doing today. And with that, I'll turn it over to Hilary.
Okay, thank you so much for the really nice introduction and for inviting me here today. And I am disappointed that I can't be there in person with you, but thank you for accommodating this way. I very much hope that what I have to say today is helpful for you as you move forward. I think we are cresting a wave in terms of food as medicine, and it's so exciting for me to see so many communities taking such a deep dive into this work, and it's hard. And so I'm going to try to talk today about both the challenge and the promise. So I know that you guys are food as medicine experts, but there's method to this madness by starting with my own definition of food as medicine, my favorite definition. And this is the way this definition goes is the integration of a specific food and nutrition intervention in or in close collaboration with the healthcare system. And if that's going to become important in just a minute. And although a lot of food as medicine interventions were originally really targeted for people with or at high risk of food insecurity, I think probably most of you are in the room because of this heavy momentum towards targeting people who are with or at high risk of certain health conditions, often diet related. Now, part of the challenge of food as medicine programs is that there are lots and lots of different models out there. From the perspective of the healthcare system, in trying to think through what are the buckets or what's the typology of food as medicine programs, my experience has been that healthcare systems like to bucket it into three programs that are into three types that to some extent really help position what their role is in the program. The on-site programs, which the healthcare site tends to lead, like food pantries in the clinic, like bringing a mobile food distribution to the clinic, or embedding a SNAP eligibility worker in your program, in the clinical setting. And then those programs that tend to be spearheaded by the community, working in collaboration with the healthcare partner, like medically tailored meals and groceries, like the food pantry or produce prescriptions. And then the whole world of federal nutrition programs like SNAP and WIC. And from my perspective, when you offer a clinical referral into these programs, that clinical referral really serves as a food as medicine program. So this is the way that I see the universe that I'm going to be talking about today. And I want to orient us by thinking about what is the theory by which food as medicine programs might work. And although this may seem simplistic to many of you, I think it's really important that we start here. The theory of change is very similar to the theory of change in screening for any other clinical condition, like colon cancer, for example. The idea is that you might be able to identify food insecurity by a positive clinical screen, that you would be able to refer someone to a food as medicine program where they would enroll, and then you would see improved diet quality, food security, and satisfaction. And that improvement in diet quality, food security, and clinical satisfaction would result in an improvement in health and utilization outcomes. So easy to say and to put on a slide, but we run into problems. It is not nearly as easy as it looks on this slide, and I know everybody in this room is very familiar with the challenges. But from understanding where we are from a food as medicine framework, I'm going to highlight just a couple of challenges that I keep seeing over and over and over again. So if you're seeing these challenges, then you're in very good company. The first is that it's very, very difficult to get data from healthcare to a community-based organization and to a food vendor, and especially to get that data back again so that you can do evaluation, quality improvement, understand if what you're doing works. This is a really key challenge. The second challenge is even just getting that information into the electronic health record is often very challenging. Can we figure out within the electronic health record who is enrolled in a food as medicine program? There have been a lot of challenges with community organization capacity to provide food, how, when, where, and at the price that healthcare desires. And I bet that you guys have been diving into that a little bit too. And then there's a lot of fragmentation of the ecosystem outside of healthcare, which means that this is not an easy task. And what do I mean by fragmentation outside of healthcare? Well, I mean it across two dimensions. One is there are a lot of ways that people get food. In the dark blue boxes there, you see the ways people get food through regular shopping channels. And in the light blue there, you see the way people might access food through the charitable food system. These entities rarely connect with each other. There's few mechanisms to connect healthcare with any of these systems. And then there's fragmentation across our food as medicine programs. And this is especially important because the food as medicine program that you need today, on the day that you maybe are discharged from the hospital from a congestive heart failure exacerbation, may be what you need for the next 3 or 6 or 8 weeks. And it may not be what you need in 6 months when you're feeling better. Or you may be very able to utilize SNAP today, but in 2 or 3 years, another intervention may work better for you. And the ability to move seamlessly across these programs has proven to be really difficult. So it's very hard to be interactive in the format that we're in today. But I'm going to ask you to just think for 1 minute about what you think the largest food as medicine program is in Kansas. And if you're really brave, you can whisper your answer to the person next to you. And then I'm going to tell you what I think is the largest food as medicine program in Kansas. And that is WIC. So there are a lot of naysayers in the room, and maybe not in the room, there's a lot of naysayers in the world about how impactful food as medicine interventions can be. And I asked them to think about WIC, and this goes back to the definition I started with in the beginning. Do we have a program that provides nutritious food in WIC? Yes. Is it integrated with the healthcare system? Yes. And why is this really important? Because if you say to me, food as medicine programs can't be scaled, we've already proven that. WIC is in every single county in the United States. Food as medicine programs can be scaled. And then you may say, well, we don't know if food as medicine programs can impact short and long-term health outcomes. And I would say to you, we have proven that. WIC shows us that food as medicine programs can very effectively improve short and long-term health outcomes. So I want to start us in this grounding, which is a little controversial. Not everybody agrees with me on this, but I think it's really important for understanding where our future challenges are and where our opportunities are. Okay, so what do we know about the impact of food as medicine programs in 2023? This is my general overview of our food as medicine programs. And as I just mentioned, WIC has very strong evidence that it improves diet quality, improves food security, improves maternal and child birth outcomes, and improves child academic performance. So when people ask me about the potential impact of food as medicine programs, this is the first place I go because the data is so strong. I don't consider SNAP a food as medicine program, so I'm graying that out for right now, but I do want to mention that there is very strong evidence that SNAP also can improve health outcomes. And then when we get into medically tailored meals, medically tailored groceries, produce prescription programs, and these on-site programs, the data is much, much less robust. And I know now that Dr. Wetherill is going to cover the Aspen Institute Food as Medicine Research Action Plan later on, so I'm not going to give you a lot of information. What I am going to say is that the number of studies is small. You can see here 10, 12, 27 studies. Very few of them have a control group, which would make them a much more rigorously designed study. Most of them don't have very many people in them, and there's only been 2 randomized controlled trials of medically tailored meals programs that I am aware of at this point in time. Let's now just focus on those programs that are implemented in the healthcare setting and start with a referral based on a positive clinical screen and result in a program to support food security and dietary intake. This is another excellent review of the literature that you might pull if you're interested in this. It's called Food Insecurity Interventions in Healthcare Settings, a review of the evidence. It's a few years old now, but not many, and they were able to find 29 studies in the literature, 17 food referrals, 9 produce prescription programs, and 6 direct food provision. And here's the summary of their results. You can see in the top lines, resource use, food security, health behaviors, by which you might think fruit and vegetable intake or dietary intake. There's pretty good evidence of improvement. And once you start shifting towards the longer term outcomes like health and cost and utilization, our data is really, really poor. And it's been very difficult to demonstrate effects. So why is the data so limited? And does this mean that food as medicine programs don't work? And I'm going to argue that it does not mean that food as medicine programs don't work. So first of all, here are some challenges that I think many of you are probably familiar with if you are engaged in evaluation of your own programs. Almost all food as medicine programs, not talking about WIC now, obviously, reach only a very small number of people. And programs that reach a small number of people are not suitable, and I would argue not ethical, for examining health outcomes, utilization, and cost, because you really are not going to be able to get a good assessment of changes in health outcomes, utilization, and costs. And we'll talk a little bit more about why that is in a minute. They almost all offer a relatively small dose and duration, meaning many programs are 6 weeks, 3 months, 6 months long, and a dietary intervention is likely to require a higher dose of intervention for a longer period of time because we're focusing on prevention. Again, not suitable for examining health outcomes, utilization, and cost. Most evaluations are single site programs, meaning just implemented in a single clinic or a single health system. And so it's hard to understand what it means for the field as a whole. And so the bottom line is you need a lot of data to show an impact. And most programs don't have nearly enough evaluation funding available for this. So if you're thinking this is really hard, you are correct. It is really, really hard. And if you haven't cracked this nut, neither have I. And so you are in very good company. So why do we need so much data to prove impact on health outcomes, utilization, and cost? Well, this comes down to this concept of population health. Food security and nutrition programs are generally better at prevention than at treatment. They're expected to have their impact over a long length of time, and they're generally proven by their small effect on a large number of people rather than a large effect on a small number of people. Most evaluations are designed to detect a large effect on a small number of people. And if you have a small number of people in your program, by which I might say less than 100 or less than 200, then you're likely to only be able to detect a large effect. But what we're really looking for in a dietary intervention is a small effect over a lot of people. And to show an impact, if you anticipate a small effect, you need a lot of people, a long duration of treatment, a high dose, and a long duration of observation, meaning I need to follow people over time, 3 years, 5 years, 10 years, 20 years, to see if my patients with diabetes are less likely to develop amputations, to see if my adults with obesity are less likely to gain weight in the future, etc. Okay, so that's the challenges. Where are the opportunities? So before I get to the opportunities, I want to caveat this by saying I have a lot of slides coming up that reference produce prescription programs because there's a lot of momentum here and a lot of thought leadership here right now. But produce prescription programs may or may not be the best program for your clinic or your community or your patient population. If you're doing something different than a produce prescription program like medically tailored groceries, the concepts are still relevant. So just change the phrase when I say produce prescription program. So I'm going to start just to orient you by giving you a couple of opportunities for the field. And then I'm going to talk for a minute about opportunities for your program. So the first opportunity for the field is to access large amounts of data at one period of time that would allow us, again, to detect a small effect over a large number of people. This is called population health. One example of this would be the GusNet produce prescription programs, which I know you're going to talk about later, so I won't spend too much time talking about it. But I'm just going to give you in this picture here the ecosystem of produce prescription programs, which have exploded across the US, and there are now hundreds of programs up and running. And if it were possible to look at all of those produce prescription programs at once, then you would have a large amount of data suitable for doing this type of evaluation. There are also opportunities with large health systems that have a single electronic health record. A couple of examples might be the VA or the Indian Health Service or other integrated health systems where you could look across many, many, many people in many different settings. And then the third opportunity would be health insurers who are able to see claims data. And if we were able to identify for health insurers which of their participants were enrolled in food as medicine program, we might be able to look at utilization and costs over an entire large population of people. This is, I think, where we're going to finally get that slam dunk impact evaluation data that we need. The next opportunity for the field is modeling studies. And in modeling studies, we do fancy mathematical algorithms that allow us to estimate based on a change in dietary intake or an improvement in fruit and vegetable intake, or in this case, an increase in fruit, nut, seed, vegetable, whole grain, seafood, and plant oil intake, what would be the long-term cost over a large number of people. So we can't see this very well in the data, but we can use a mathematical model to try to estimate it. And these modeling studies have very, very positive impacts. In this one, and there are many out there, if insurance covered 30% of the cost of eligible food, it would result in a $100 billion decrease in healthcare utilization over the US in the population's lifetime. It would be cost effective after 5 years. 120,000 cases of diabetes would be prevented or postponed. 3.28 million cases of cardiovascular disease would be prevented or postponed. And it would be more cost effective than many currently covered medical treatments. This is phenomenal. Why are we able to see such big, phenomenal results? It's because we're looking across the entire United States. Okay, so those are my opportunities for the field. And I'm going to give you what I think are opportunities for individual programs. And I will acknowledge right here that there are many people who don't agree with me on this. And there are probably many people in the room who don't agree with me on this. And so I'm sorry for having to be the person to say it out loud, but this is what I believe. We have already proven beyond a reasonable doubt that nutritious diet, increased fruit and vegetable intake, and food security lead to better health. That is not something that I think we need to relitigate. And so what do we need to do as individual food as medicine programs? Well, our theory of change, going back to slide 3 or whatever, was that our programs would increase fruit and vegetable intake and food security, and therefore lead to better health. If we take it on faith that that right-hand arrow is going to happen, then this is our job. Our job is to prove or to show or to demonstrate that our programs can increase fruit and vegetable intake and increase food security. And it is my evidence-based opinion that better health will happen if these programs are implemented at scale and if the dose and duration are sufficient to have an impact. All right. Another opportunity for individual programs, I think you guys are going to talk about this later, so I will just preface it. Another way of getting access to a lot of data over many different programs is to use the same metrics for evaluation across many different programs and then to put all your data together so you have more participants and more sites than you would have with your just evaluating your own program on its own. And fortunately, there's been a lot of work to try to develop these shared metrics through the Nutrition Incentive Hub. And I know that that Chris Long and Carmen Biker-Shanks are going to talk about that later on, so I won't talk about it here. But I will just mention to tee that up that if you are not sure how you want to measure food security or fruit and vegetable intake or SNAP or program satisfaction, rely on the work of others because a lot of work has been done here, and that enables you to pool your data with the data of other groups. So if we go back to this concept of population health needs to be, or interventions to address population health need to be evaluated differently than, for example, medical treatments that are intended to have a large effect on a small number of people. Medical treatments, the only metric of success is generally effectiveness, the E of the RE-AIM framework. But as we talked about just a minute ago, when you're talking about interventions for population health, just because you have an effective intervention doesn't mean it's going to have any impact on population health. Why not? Well, it may not reach enough people to make a difference. It may be so clunky to implement that nobody can do it. It may be so difficult to find funding for it that it can't be maintained. And so the RE-AIM framework helps us structure the evaluation or the understanding of a program that is intended to impact population health, where we fall into a trap of only trying to understand effectiveness and not trying to understand the reach, adoption, implementation, and maintenance. So I'm going to quickly give you just a couple of ideas about what are these other metrics that we have to understand in a food as medicine program in order to understand if it's helping align us towards population health. The first is reach. How many people could be served by your program? How many are actually served? Are we serving the people that we want to be serving, or the people who are most at risk not being reached by our program? Because, for example, they're in more rural communities, or they don't come in to see the healthcare provider as frequently. Effectiveness we talk about a lot, and I know you're all familiar with it, so I'm not going to spend any time on it. But I do want to say that we think a lot about the outcomes we intend to achieve, and less sometimes about whether those outcomes are consistent across subgroups. Is everybody benefiting from them, or only certain people? And are there unanticipated consequences? Oops. Adoption refers to whether you have the systems in place to deliver the intervention. How hard is it to deliver? And is it so hard that the clinics really aren't able to keep it up? How many clinics could participate? How many clinics actually participated? How many started and then realized, wow, we can't do this? Are there differences between clinics that do and do not participate? And then on the flip side, why could the clinics that were successful at this, why were they able to do it? And how can we create that same miasma in other clinics so that they may be successful at this implementation? Implementation. What do we have to do to implement successfully? Is that being done as we originally intended? Or did we set out to do program A and we had to pivot to program B? That may be great to pivot to program B if it's more successful, but do we also think that it's going to have the same reach and the same effectiveness and the same adoption? What's the cost of implementation And do the clinics find it acceptable, or is it such a drag on the clinic that we don't think it's going to be able to stay the long haul? And then finally, maintenance. Are there lasting impacts? Are your clinics still supportive of this at the end? Is funding adequate to maintain the program when your current grant is over? Now, I know these are really challenging questions on one hand. On the other hand, in many ways, they're easier than effectiveness. And if we're going to do the kind of improvement and implementation of best practices that are going to get us to scale and are going to get us to the effectiveness promise, we really are going to have to dive into these additional questions of reach, adoption, implementation, and maintenance. By the way, if you think to yourself, yes, I want to do this, the Re-AIM website includes a number of exceptional tools and resources to help you structure the evaluation of your own program. So what's the vision of the future? Just the Food is Medicine program, or what needs to go around it? And I would say that the final opportunity I want to talk about today is what the future might look like in the clinical setting for a Food is Medicine program. And I'm going to rely here on the National Academies of Science, Engineering, and Medicine 5 A's framework for strengthening social care integration. And they identify 5 ways in which healthcare can dive into social care in a way that will positively impact health outcomes. 2 focused on individuals, adjustment and assistance. 2 focused on communities, alignment and advocacy, and 1 that crosses that awareness. So what the heck does that actually mean? Let me tell you what that would mean for food security. Awareness means that in the clinical setting, we would be screening patients for food insecurity. We would know who needed additional support to access nutritious food. Number 2, we would be adjusting our treatment based on social risk. For example, we would be adjusting our insulin doses to avoid low blood sugar when food budgets run low. Number 3, we would be enrolling patients in Food is Medicine programs when they screened positive, or assisting our patients to access nutritious food. But we would also do these other things in the clinical setting. We would be aligning our healthcare interventions with what's going on in the rest of the community and investing in the community in a way that increases access to nutritious food for all. So what that might mean is co-locating a food program in a clinical setting, another definition of a Food is Medicine program, partnering with a CBO, sharing data about health disparities with a food security-based community organization. And then finally, advocating, as an example, for streamlined enrollment into SNAP, because we know that SNAP is the best food security support system out there. And if we can get our patients into SNAP, they will be more likely to be able to access nutritious food that's good for prevention and treatment. So, we've all seen this before. I want to ground us in the unbelievable epidemic of diabetes that's exploded across the US. And I'm using diabetes as an example here because I hear that many of you are focused on diabetes. This is not a simple problem, but I want to give us as an example the tobacco field and where it stood 30, now probably 40 years ago, when we had a tremendous problem that seemed impossible to solve because there were so many players at the table and behavior change was so difficult. And what was tobacco able to do? The tobacco cessation movement was able to bring in all kinds of different sectors, all kinds of interventions at all kinds of different levels in order to create massive reductions in tobacco use across the United States. That is considered one of the greatest public health wins in the United States. How did we do it? All different sectors were doing their part. Physicians were prescribing medication. In this case, we'll call those a Food is Medicine program. Housing was not allowing people to smoke inside. Bars were not allowing smoking. Airplanes were not allowing smoking. Cultural norms were changing. How do we do all of that? It's by bringing all sectors to the table. And I think we are at a moment where healthcare is really at the table leading this charge across all different sectors of the United States. And that is enormously exciting for me as someone who's been working in this space for more than a decade. It is my thought that this very famous slide of the misalignment between healthcare and social care in the United States, which probably all of you have seen, which shows the extent to which the US overinvests in healthcare and underinvests in social care in comparison to all the other developed nations across the globe. It is my thought that this is going to slowly change. And this is not going to be a slide that we continue to show 10 years from now, because we're really seeing healthcare dig into this really challenging work of moving upstream. We are clearly, with food as medicine programs, taking on the need to address individual social needs like food security. And I am very optimistic that we will be addressing social determinants of health from a healthcare setting as well, if we continue down this path. Not here yet, but if we continue down this path. So I am going to open it up for questions in just a minute. I'm going to give you my conclusions, but I just want to say I do think we are cresting a wave here. It's very exciting for me to see so many people in so many regions of the country and so many communities invested in doing this hard work. And I will conclude with this. If there's one thing you can take away today, it would, from my perspective, it is that WIC is already proven to be scalable and to have an impact on health outcomes, and it is an exceptional food as medicine program. There is tremendous momentum here, and I think that that momentum is going to translate into scale over time, but evaluation is hard. I don't think you need to reprove that nutritious food and food security are good for your health. But I do, and I think you need to right size your evaluation for the size of your program. It's not just effectiveness that's important for interventions such as these or programs such as these. It's also the reach and the adoption and the implementation and the maintenance. If you're looking at effectiveness, concentrate on those metrics that are similar to all others, to many other food as medicine programs, like food security, dietary intake, satisfaction, and redemption rate. And use the same metrics others are using when you can. And finally, thank you, Dr. Wetherill, for doing the Notebrun plug. If you are interested in joining the Notebrun network, please feel free to use that email address right there, notebrun@ucsf.edu. And thank you so much for inviting me to talk today. I will pull down my slides so that we can answer some questions.
All right, thank you so much. Will everyone join me in giving Dr. Seligman a hand, please? And a very special thank you, because I know you are not feeling at your best today. No one would know that. You've got your hot tea in hand. We've left plenty of time for questions, so you just let us know when your voice starts to give out. And I want to remind everyone in the Zoom room, they can just put their questions in chat and we'll make sure those get read aloud. I'm going to take the liberty, since I have the mic, of asking the first question, and then others, if you have a question, just raise your hand, and Mitzi will run around with the mic, or Brandon will. So gosh, you give us a lot to think about. My first question for you might not be what you expect after all that wonderful data, but I've been following your work for over a decade. And I've always wondered, what brought you into this work personally? Because you obviously have a passion for this. You are one of the pioneers, and I've always wanted to know that backstory.
Well, thank you for asking that. I'm a primary care doctor by training. I worked in our safety net hospital in San Francisco. I'm still working our safety net hospital, but about 15 years ago, or 20 years ago now, my goodness, I had a patient who had a hemoglobin A1C in the pre-diabetes range. And I asked him, like I asked many of my patients, what he ate for breakfast, lunch, and dinner. And when we got to lunch, he told me that he ate every day a piece of Spam between 2 cinnamon rolls. And just sit there for a minute and think about a piece of Spam between 2 cinnamon rolls. It shocked me. And I thought to myself, what could possibly drive somebody to have that lunch every single day? And the answer was that he had about $1.50 per day to spend on food. And he knew that that lunch would fill him up and keep him full until the next day when he could eat breakfast. And I thought to myself, I'm a primary care provider. I am tasked with supporting this man in his prediabetes, not progressing to diabetes. And I can prescribe him a medication. I can give him metformin. But really what this person needs is some access to food. And I can't do that as a healthcare provider. And so healthcare has pushed me into this space where these very important tools for health are not at my disposal. And the only tools available to me, trained as a primary care physician, as an internist, are expensive medications with side effects. And that really, my desire to fix that problem and reorient healthcare to bring healthy food back into our own purview is what started me down this road.
That is a really powerful story. Thank you for sharing that. Other questions in the room at this time? If you just raise your hand, Brandon or Mitzi will come at you with the mic. We did have a question about earlier yesterday when we were chatting before this about your role with the recent historic White House Summit on Hunger, Health, and Nutrition, and sort of the role you played in that and what you think and hope may come out of that convening.
Well, my personal role was, it was a thrill of a lifetime to be sitting in the room, and so that was the big part of it. I did provide some advice and context for the team that was supporting the drafting of the document, but I had no more impact in its creation than dozens and dozens and dozens of other people. I do think that it was very much a team effort. I will say that the energy in that room was spectacular. And the thought that there would be a whole of government, this is what they call it, a whole of government approach to addressing food insecurity and inadequate diet quality across the US was really moving. And I hope that that momentum will transfer into more sustainable funding models for programs like this in the healthcare setting. And I don't know how much in the weeds that you guys have been getting, but mechanisms by which Medicare and Medicaid and ultimately other health insurers might be supporting food as medicine programs in the same way that they support other medical treatments, it would be, you know, the long-term goal from that perspective.
Yes, that's very much the goal we have here in Kansas, is working toward that policy payer end game, while at the same time trying to implement and build a system into which, when you have that payment system in place, it would actually work. And this morning we heard from a lot of the clinics that are trying to do the hard work on the ground. Brendan, did you have a question?
Yeah, I was just you alluded to this a little bit in your talk, but for a room full of clinics that are just starting on this journey, that are finding it very difficult, you know, what are your words of wisdom to kind of keep them moving forward?
The implementation, very difficult. I just want to make sure I understand.
Yes, yes.
There are many people who will say work such as this is the job of public health, not healthcare. I want to acknowledge that tension, that the public health sector is in some ways, very well positioned to do this work. And healthcare is learning. I would first say thank you for being able and willing to dive into that very hard and necessary work. I do think that this work is going to transform healthcare in the United States. It may take a while, but it will happen, and you will have been a part of it. And what I don't want to detract from that is this desire to prove the ROI, because really where the hard work is and where we need to be spending our energy is how do we design and implement the best program in this moment for the most number of people and for the people who need it the most. That is our challenge. And that is an issue of continuous quality improvement, of problem solving, of the detail work, of the logistics, of having a clinical champion who can continuously remind people how important this work is, of talking to patients and understanding their experiences with the program, where it worked for them and where it fell flat. That's really the work that we need to be doing. And all indications from other programs across the country is that when we turn our attention to doing that work, we can be successful. But it isn't easy. So you are not the only one having a difficult time. You are also engaged in the proof of concept in many cases in your own health system and creating the path that hopefully many will follow after you. How's that for inspirational? I don't know. That's as inspirational as I get.
We're all floating here. So yeah, it's great. One quick follow-up. We talked about the clinics that are implementing. Any advice for entities that fund this work? So from the funder perspective, what's your advice?
Well, the push towards proving health outcomes and the return on investment and the cost effectiveness is often coming from the funders. I'll be totally honest, and at the risk of antagonizing the funders in the room, I would push the funders to examine or to bring to the table the value of all of these other dimensions of a good program. Are patients satisfied with them? Do they feel like it is a dignified way for them to obtain food? Are we missing the people who need it the most? When the funders reinforce that, that's really when programs can get behind that work. So that's one. The second is that if you want an immediate impact on a small number of people, we have to pay really close attention to dose and duration. And I don't think that 6-week interventions are likely to be long enough to create long-term behavior change. So in our modeling studies, there are 2 ways we can think about this. We can think about starting people on a food as medicine program and they stay on that program forever. And that would be a way of maintaining the increase in fruit and vegetable intake. The other way is people stay on a food as medicine program for a brief duration of time, but long enough that some behavior change is supported that persists after the intervention is pulled away. Now, particularly in a food insecure household, the entire behavior change isn't going to be maintained because you need the extra money. But some of the behavior change may be maintained. In our own produce prescription program, we estimate this to be 50 to 75%. After we pull the voucher away, which we have to do after 6 to 12 months in order to reach more people, we see 50 to 75% of the impact remains, not in the most highly rigorous study, so I want to give that caveat. But it's going to take more than 6 weeks, and it will probably take more than 2 or 3 months. And I think funders need to be aware of that.
Well said. Well said. Jerry Jones put in the chat box, this was quite inspirational. Is that the same Jerry Jones that's sitting in the room? Okay, so we have 2 Jerry Jones. Well, I'm sure you thought it was inspirational as well. I was trying to figure out how that worked. Does anyone else have a question for Dr. Hilary? Oh, we've got Dr. Michael Williams, a primary care physician who teaches culinary medicine, has a question.
So it seems like there's 2 components to most food as medicine programs. One is providing food, which obviously is important, but the other is the education component, and there's a lot of different ways to educate people. Is there any data or any maybe just suggestions on what works best? Is just giving food enough? Is there a better way to educate? Is there data that says you should do one thing or another, or is it just do the best you can and hope it works?
That's a great question. I will say my reading of the literature is that most people, not all, but most people in the United States know the basics of a healthy diet and probably know enough of the basics. More fruits and vegetables, you know, fewer ultra processed foods. Most people know that. What is much more difficult is to change behaviors, and particularly to change behaviors when people are accessing unfamiliar foods. So I think the place where this work really is important is when people have less choice over the foods they're accessing, and we need to provide support for how to use those less familiar foods. The nutrition education that I think works the best is nutrition education that is environmental, meaning it's at the grocery store to say, like, this one's healthier than this one. It's at the, you know, the point of sale or the point of collecting the food, or it's happening on your Instagram account, or, you know, whatever way you're getting it. And that one-on-one nutrition education can be transformative for some people who really can engage with it. But I don't think we necessarily have one nutrition education system that's going to work for all people, because the needs are different and behavior change is really complex. And it's not just about education of what you should eat. In the same way, it's not just about access to food or affordability of food. We need all of them together. And this is why I end a little bit on that tobacco example, is because food as medicine programs alone are not going to change the trajectory of the diabetes intervention. But if we're aligning ourselves with culinary medicine movements, and we're aligning ourselves with the work the charitable food system is doing, speaking of Jerry Jones in the room, and we're aligning ourselves with the work that that public health is doing, that's when we start to move this great big ship.
Well, that is a very inspiring note to end on. Unless any, if your voice will, it looks like we have 2 more questions. If your voice will let you continue.
Yeah, I'm good.
Okay, and please introduce yourself as you ask your question.
Good morning. Gina O'Brien from USDA Food and Nutrition Service in the Mountain Plains. Thank you so much for your talk. I was just curious if there have been some good examples of programming or the ability to implement a similar wellness type food as medicine for the frontline healthcare workers. I think if they were benefiting from the outcomes that we know are proven, they become the best champions. So I was just wondering if there are examples of that.
I love that comment. I think that there are. And I don't know specifics. My suspicion is that Kaiser has done this. That seems to be sort of in the back of my head, but I don't know for sure. What I do know, and I will emphasize this to you, although it doesn't really answer your question as much, is that patients sometimes see their healthcare providers as living in another universe and not really understanding the barriers that they face to healthy and nutritious food. And across many dimensions, that is probably very true. And to the extent that we engage healthcare providers in also experiencing in real time the challenges associated with behavior change, the more empathy it may create with our patients. So I don't have specific examples for you. I will, though, actually, since we brought up Kaiser and large integrated health systems, I will just mention, for those of you who are still sort of thinking about long-term impact and return on investment and utilization, that the health systems that tend to do the most of this are the health systems that hold on to their patients for the longest duration of time. Because they're the ones who have sufficient time, as we talked about earlier, to see the benefits of a program like a food as medicine program. If your health insurer, the average duration of enrollment is only a few months, or a year or two, it's going to be much less compelling to make that financial argument. And so we have to think of other ways to position the importance of food as medicine programs that don't rely on coverage under one insurance system for, a decade at a time.
Hi, Keisha McClish-Couts with Common Ground Producers and Growers, and we are a mobile food market that takes produce to our senior sites. I was wondering, how can we get that clinical piece into areas where they cannot access transportation to get to the clinics? Because it seems for us, because we're boots on the ground, we're in the clinics a lot, that we don't see those seniors and those people that have a lack of transportation able to get to the clinics. So how are we able to access the food as medicine and provide those services into our senior sites or into those sites where they don't have transportation?
Mhm. Thanks for the question, Keisha. And here's where I fall back on this complicated ecosystem. There's a lot of disadvantages to the complexity of the ecosystem. The advantage is that there are opportunities to create such a quilt and that nobody can fall through the cracks, or that fewer and fewer people fall through the cracks. So what does that look like? I worry a lot that food as medicine programs will widen disparities because they are only reaching people who have access to healthcare. So we need to make sure that at the same time as food as medicine programs are being scaled, that we also have other programs that are able to reach people who aren't able to get into the clinical setting, exactly like you say. And that's where we start thinking about other models like home delivery, like online ordering, like mobile opportunities. So in my long-term vision across many, many different programs, what we need is to create that quilt. As many people as possible are getting their services through SNAP or WIC, because then it's a long-term program. You shop at a regular store. You do things the way you've always done them before, and we are able to catch through this sort of Swiss cheese sieve that we have all the other people who are on SNAP, and it's not enough to access nutritious food, or who don't qualify for SNAP or for other reasons are not interested in enrolling in SNAP. And we have to be able to meet those people where they are. If it's at the clinic, great, that's your job. If it's not at the clinic, then we need other sectors to help us reach those people. And that's exactly why it's so important to think about all the letters of the REAIM framework. Because if you can't reach those rural people, if you can't reach those people who aren't coming into the clinic regularly, then your impact is going to be limited. And there may be things that you can do to increase that reach.
Thank you. You are so setting us up for a discussion we're going to have this afternoon about the ecosystem. We do have one quick question online. I'll let Tiffany read it.
Okay, the question is, are any of these programs also capturing improvement in behavioral health / mental health outcomes?
It's interesting. I was just on a call about this the other day. Like all outcomes, physical health and mental health outcomes, I put into the same bucket as being very challenging. We have very good data that food insecurity is poor for your mental health. We have some data that that programs that better support food security improve mental health. But we have the same challenge with mental health as with physical health, that proving all of the arrows along the chain from food as medicine program to behavior change to mental health improvement, that entire chain has never been studied to my knowledge in a single intervention. Now, it is hard for me to believe that if you are effectively supporting better dietary intake in a dignified manner that also improves food security, you're certainly not going to have a negative effect on mental health. And it's very likely, I think, based on the data that we do have, that you will have an improvement in mental health. But again, to my knowledge, there's never been a randomized control trial that showed that.
Sounds like a good research question for a PhD student out there. I want to thank you again, Dr. Seligman, for giving up your time today, drinking your hot tea, answering our questions. I think our minds are buzzing with a lot of things you've told us. Would you all join me again in giving our hand? Thank you so much.
Thank you all.
We enjoy the rest of your Friday. Thank you so
Take
much.
care.